Good morning, everyone. On behalf of York Hospital, I'd like to welcome you to this morning's webinar. Today, we are fortunate to share some time with York Hospital oncologist, Dr. Marilyn McLaughlin, who will address the impact of COVID-19 on cancer care over this past year. She will discuss the manner in which COVID-19 affects cancer patients, the role of both the oncologist and hospital throughout the pandemic, and the ever-evolving guidelines related to triaging, surgeries, and clinical trials. However, before we get started, we do have a few quick housekeeping notes to review with you. Unlike traditional Zoom, where you see everyone's faces during the meeting, during this webinar, you will only see the presenter's face and the slide. As participants, your audio has been muted, so if you do have a question, you should type it into the Q&A button located at the bottom of your screen. Please do not use the chat or raise hand icons, as those will not be monitored during this presentation. If you ask a question through the Q&A feature and it is not answered during this meeting, please feel free to email us at info@yorkhospital.com and we'll reply after the webinar concludes. Additionally, today's webinar is also being recorded and will be available for viewing on York Hospital's YouTube channel early next week. So once again, thank you very much for tuning in with us today and spending this time with York Hospital. We hope you find the information helpful, and we're pleased to get started by turning the program over now to Dr. McLaughlin.
Hello, everyone, and welcome. First of all, I'd like to thank York Hospital for having the faith in me to do this presentation and to speak on this very important topic, cancer care in the time of the COVID pandemic. As we begin our talk, I think we need to just, have a couple of definitions just to know, for example, what is COVID? COVID is a virus that has caused a worldwide outbreak. It was first reported in December of 2019, and it was thought to originate in China. It's also known as SARS-CoV-2. It is actually a family of viruses that cause such things as just the ordinary common cold. However, it can also cause more serious respiratory diseases, such as severe acute respiratory syndrome, and also MERS, known as the Middle East Respiratory Syndrome. Variants exist. However, we will not be speaking of those today. There's some things that are known and some things that are known or unknown about them. Keep in mind that we now have vaccines for COVID-19, and we can rest relatively assured that the ones we are using here in the United States does cover the majority of these variants. The question is, how does COVID-19 affect our cancer patients? For many patients who are being treated with cancer, whether or not it's with chemotherapy or they've undergone stem cell transplantation, all of these various interventions can weaken their immune system. And so in order to treat our patients, we always have to be mindful about how we are treating them and how this will affect them, especially with the COVID-19. If someone was treated for cancer many years ago, it's likely that their immune system is now normal. It's always important, if there's a concern in regards to this, to speak with your PCP or your oncologist. There's many unknowns regarding the virus and cancer patients, but studies does show that cancer patients are more susceptible and can have worse outcomes when they are exposed to the COVID virus. How does oncologists work during the pandemic? Well, we had many guidelines which came at us fast and rapid. We had guidelines such from ASCO, which is the American Society of Clinical Oncology. We had guidelines from the NCCN guidelines. We also had from the Society of Clinical Oncology, and most importantly, we depended on our affiliated hospital, MGH. Providing quality care during a pandemic is very important. And one of the things that we were all geared towards was basically patient protection. We followed guidelines, like I said, from ASCO or other networks. As we know, COVID affected all countries, so we were not alone in how we were thinking about managing patients. One of the things that came into being very early in the pandemic is the use of telemedicine. What role did this play? Well, I must say it was the lifeline between the physicians and the patients. It allowed us to see our patients much more frequently than would have been possible if the patient would have to come in to be seen on an ongoing basis. We will talk about that a little bit more later on. Remember too that the patients were initially not tested, so we were treating patients while we were dealing with the ongoing pandemic. And in the way in which we treat patients with systemic chemotherapy affected their immune system in an ongoing way. Our facility also is an infusion center. And so we have to think that all patients coming through were getting various types of treatments, immunotherapy, chemotherapy, medications for rheumatologic disorders or for GI disorders. The oncologists had very little data to go on, but we did know that depending on how many illnesses a patient had, we had to be extremely vigilant in making sure that those patients were always kept healthy and away from anyone who were infected with the COVID virus. As oncologists, we have multiple ways in which we treat our patients. That could be neoadjuvant. And so that would mean that a patient would come in, they would be diagnosed with a malignancy or a cancer, and we would actually give them chemotherapy first. Or we would be treating them with adjuvant chemotherapy. And in that way, they would have already undergone surgery, and then they came in to receive additional treatments to be sure that we were able to affect their outcomes in a positive manner. Either approach that you take can be very aggressive. Other patients were undergoing what we call chronic treatment. So they have already been treated and maybe they had metastatic disease, and so we were continuing treatment to give them good progression-free overall survival. In all instances, quality of life became the major marker for many patients. Patients were concerned about getting additional illnesses. So if they got chemotherapy and their white count was lowered, that would mean that their immune system is being affected. And so they had so many things that they had to concern themselves about. And our role as oncologists was to be sure that we were treating patients, but at the same time, not making them susceptible to a virus that we knew so little about. How did the hospital play a role in this? Well, the hospital was basically our number one safety measure. They provided guidance in regards to how we should screen our patients. Prior to scheduling any appointments, patients needed to be screened. There were specific guidelines as to when to schedule patients. It was actually a combined effort between the hospital, the quality team, and the nurses, the physicians, both inpatient and outpatient. It was very important that everyone had PPEs, personal protective equipment, and this was made available for patients, for their caregivers, and also for physicians. Physicians also were given an added protection of having goggles. Again, telemedicine, which I mentioned before, became a lifeline for many patients. There was limited access to the facility. What happened was at the doors, there was screeners put in place so that we could screen all individuals and be able to protect all those that we could from being exposed to the virus. There was physical and social distances put in place, and there was facility signage with directions implemented so that patients could know which direction to come in and which direction to go out. What we do know about our patients in cancer is that international surveys showed differences worldwide in the approach in which cancer patients were treated. Us as community oncologists look towards our larger center, and MGH was a key player in this. We were able through telehealth to be able to have access to the oncologist at MGH in whatever specialty we wanted. We were able to get our patients seen in a timely manner, and this was all facilitated through telehealth. I'm not sure where telehealth will go after this, but I have a feeling a lot of our patients like it so much that they may actually have it kept in place. As the pandemic went on, we realized that a lot of things that were required prior to our patients being treated. So COVID-19 testing was then put in place and was required for all new patients who were to start chemotherapy. A lot of our patients need to have what we call venous access to get treatment, and that's done in the hospital. And so we also put in place where testing needed to be done for all patients who were going to undergo any intervention in a hospital setting. One of the things we're proud of in York is that York Hospital's strength is that it's an outpatient facility. This was noted early in us being able to deliver care. Many times, if you're in a hospital setting, care had to be delayed as many factors had to be put in place. If you were going to be getting chemotherapy next to another patient, most patients would have gotten very scared about that. One of the nice things about York Oncology is that all patients are treated in single rooms. Your door is closed and you have access only to your nurse. To us, this presented a more efficient manner in which patients could be treated. And so we were able to actually keep a lot of patients on their scheduled visits. The patients were made to be part of the discussion. Studies shows that patients with cancer, like I said, was more adversely affected by the COVID virus. The benchmarks that MGH used, that was what we used as well. Early discussion with the patient was of utmost importance. What were their goals for care? How important was it for them to be in on a timely fashion? Age became an issue. Many patients became fearful of coming in for treatment. And one of the ways in which we facilitate just the patient being more comfortable was, like I said, through telemedicine. The fact that cancer care is personalized, so not one size fits all, which is very nice for us in oncology. And one of the ways in which we've been able to treat patients in such a fashion that we are seeing excellent outcomes, even in the most advanced stages of disease. We were able to make changes. If a patient needed to be on steroids, we were able to decrease the amount of steroids being used. We were able to use telemedicine to contact patients to see how they were doing. And so we were able to minimize risk for patients being immunosuppressed and therefore at risk. We were also able to adjust the timing of treatment for each patient. We were able to get blood work completed. Again, because we're an outpatient facility and labs are done in our offices, patients were able to get their blood work done, and we would be able to time treatment based on what was seen. For stable patients who needed imaging workup, what we did was maneuver it in such a way that images could be adjusted. So patients who were not getting treatment, who were just being monitored, we were able to delay those testings so that they were not exposed in any way that they were not, in which they were not comfortable. We did pre-screening of patients both the day before treatment, the day of treatment, and we anticipate any possible complications that we would possibly see in our patients. Patients' resistance was limited given the uncertainty and fear many had of contracting the virus. So they looked to us, their oncologist, as a way of knowing exactly what they needed to do. And we were grateful that our patients trusted us in the way that they did. In oncology, we also have social workers and also a nurse navigator. And both these disciplines were instrumental in making sure that patients were kept close to the vest. Our nurses would contact the patient the day after chemotherapy, so we would know how they were doing and what was going on. All patients, to the best that we could, was seen 1 week after they had gotten any chemotherapy, so we would know what their blood work was like. Of note, we should be very proud to know that there's limited COVID transmission that was seen in any outpatient setting. Most patients who acquired COVID got so in the home setting. What harmed our patients? I think limiting the visitors in the hospital and also the offices affected a lot of patients' well-being. We'll probably talk about that in a little bit more. Cancer care is multidisciplinary, so other disciplines were affected. Most of the surgery that was done in the hospital, if it was an elective surgery, had to be delayed. The surgeries that were not delayed were that for patients who were diagnosed with any malignancy. Prior to surgery, all patients were also COVID tested. Like I said, non-essential services were decreased, and this was part of a national mandate. Prioritizing cancer surgery was very important. Unfortunately, we saw a decrease in many diagnoses shortly after the initial surge of the pandemic. And we figured that this was based on the fact that a lot of patients were afraid of entering the hospital and they chose to stay home. Hematologic malignancies, which were usually done by just checking blood works, that was found pretty often. And usually these patients are approached in a curative manner and some required inpatient chemotherapy. We were able to do this by closely monitoring the patient and in having an early hospital discharge. We decreased hospital utilization, especially when the hospital had any higher percentage of COVID than we were comfortable with. Thankfully, our hospital didn't really enter into this period for an extended period of time. Here at York Hospital, we have clinical trials, and we have patients who are in our clinical trial enrollment. Like all other hospitals, our clinical trial was affected. Our patients who are in clinical trials have standards which needs to be kept, which means that they would have to come in on an ongoing basis for medication. They would have to be monitored, exposed to others, and so there was a mandate placed that all clinical trials should be halted during the pandemic, and this was done. Consideration will be given for continued adjustment moving forward. We have slowly reopened clinical trials, and it is our hope that we will become fully staffed and fully engaged again soon. What is the impact on our patients? Like I said before, impact on delay of surgery and treatment has been hard on patients. Although most patients had access to surgery, a lot decided to delay their care. More so on the fact that from a national standpoint, we did not know what was going on to a large extent. Transparency to patients, I think, is extremely vital. One of the things we made sure was that we were always open to discuss with patients whatever they had in mind, whatever was going on, we were ready to speak with patients. However, there were certain things put in place that affected patients. For example, in our outpatient center, all patients are able to have someone in the room with them during the time of their chemotherapy, when they visit with the oncologist, or anytime they come into the hospital. This had to be delayed. We had to put away companionship for patients during COVID. I think that became a large issue, not just on the part of the patient, but on the part of the nurses and also the physicians. As physicians, we are basically very close to all our patients. And so the thought of having goggles, face mask, and the patient having on a face mask also affected us as physicians and as patients. I'm actually told by some of my patients at times that it will be nice when this is over and they can once again see their patient's face. A fist pump or an arm pump to a patient is really not the standard of care. I'm a hugger as a physician, and it's hard not to be able to just hug your patients. I think we are opening up now that patients have gotten vaccinated. We're less, shy of saying shake a hand and making sure we keep everyone safe. Lack of companionship for patients when they initially see an oncologist, when they enter for their care, is a troubling trend, and one I hope will end pretty soon. Patients that undergo, all patients, by the sheer word patient, needs companionship and support. Oncology, hematology, even more so. I spend a lot of time on this because I'm a people person, and I think it is important for us to realize that our patients need companionship, they need handholding, and they need hugs. And so I'm hoping that as soon as we open up and we will be able to move back to what we consider to be our normal. We'll be able to have our Living Well Center back in place where patients can have ongoing support, not just from their caretaker, but from each other. We're hoping that they will be able to begin their exercise routines again. Even though we have some outpatient exercise programs ongoing, we know that patients are still somewhat hesitant to get back into that full term unless the hospital says yes. Not even the CDC, but the hospital, because there are different standards for the hospital as it pertains to all patients. A lot of patients postpone their care during COVID. We have seen that in our center, where we're getting a lot of patients come in with a more advanced stage because of the fear they had during the pandemic and putting off their care until later. One of the good things about oncology is that we're able to do a lot of personalized testing. And so patients are able to be treated even if they have advanced disease. We're not saying we cure everyone, but we're saying we're able to say to a patient, we will be able to treat you. A lot of patients comes in saying, oh no, we don't want anything done. And when we explain how oncology affects patients and how we deal with oncology and test the patients so that we can treat them in a personalized manner, a lot of patients said, oh, I did not realize that. Yes, it's no longer one size fits all in oncology. When will we revert to pre-pandemic management? Well, a lot of uncertainty still exists. As you can see, the CDC sends forth new guidelines almost on a daily to weekly basis. We will be in the throes of changing every day, and we look forward to the hospital's leadership in guiding us through all of this. There's a lot of positive signs we see at this time. We know that there's been increased vaccinations. We are almost there. Herd immunity may come about with the increased vaccinations in Maine prior to most other states. Telemedicine might still be requested by many patients. Clinical operations will most likely be more efficient. I think we have learned a lot from the pandemic in how to make things more efficient for a patient, cutting out a lot of paperwork that is we deem to be redundant, working with our quality team in the hospital to put in place efficiency avenues for all our patients. I think we will probably also transition to mixed telemedicine and inpatient evaluation. I think we will also continue to use Zoom as part of all our meetings and lectures and dealing with patients. Education and knowledge is much improved at this time. I think reaching out to MGH and having them as close partners have improved during the time of the pandemic. There have been so many safety measures that have been put in place. COVID infection screening, pre-chemo, pre-surgery. I think most patients, when I say to them, you need to get a COVID test, despite the fact that you've had a COVID vaccination, you've had your COVID vaccinations, have become very exhausted at this time, but they're always relieved when they realize, oh yes, I'm okay, my test was negative. And so we will continue to do that. I think that is my talk as I have it set up, and I would love to entertain any questions that anyone might have at this time. Again, I thank you for being here and for listening in. Do we have any questions?
I don't see any posted in the Q&A section at the bottom of my screen.
Okay.
At this point, anyway.
Okay, so some of the questions that my patients would ask me at times is, so doc, when are you doctors going to stop wearing your face mask? And I usually say to them, it will probably be the last thing that is taken away from doctors. It will be around with us for a while because we know that COVID is a respiratory virus. And so I think to keep our patients safe, it is more important for us to wear the face mask than for anyone else. So even though, you know, the guidelines might change for other places, they will most likely stay in place as it pertains to physicians. The other questions patients ask is, if I get the COVID vaccine, when am I supposed to get the COVID vaccine? And as physicians and oncologists, mostly, we've actually had a lot of back and forth as to how we can give the COVID vaccine and continue to treat patients. The way MGH does it, they put a week before and a week after. The way Memorial Sloan Kettering does it, they put a day before and a day after. So all the large institutions, they kind of juxtapose the vaccination with their chemotherapy. What we try not to do is to give the vaccine the same day we're giving chemotherapy. We also would like to keep the vaccination away from our patients at about day 7 to 10, because we know a lot of our chemotherapies that we give suppresses the white cell count. And at that point, the patient can be at increased risk for maybe having a side effect to the vaccine. A lot of our patients who are on long-term immunosuppressive therapy, such as high-dose steroids, the question is, do they have, would they build up enough resistance to COVID by the vaccination? Well, we do know that, unfortunately, a lot of patients who are immunocompromised might not mount a full response as much as someone with a normal immune system. However, we do know that having any protection against the virus is better than having none. And so if you're immunized, the level of infection you get will always be lessened. So we always tell patients, you need to get your vaccine, and you need to get both, and you need to know that you're fully vaccinated 14 days after your second dose of vaccination. And so we do encourage all our patients to get their vaccines. The good news is that almost all our patients have been vaccinated for the COVID-19. What other questions do I get from patients? They usually say to me, Doc, have you started going out and eating in restaurants and all of that? And I basically say, no, I have not. Prior to this week, there was still the CDC recommendation that you do not. I did not. I kind of think I should practice what I preach with my patients. And so I may be outdoors and I will not have my mask on if I am far away from other people, but if I'm walking towards someone, I am going to put my mask on, even though I am fully vaccinated. The other question is, do you travel? Yes, you may travel. CDC has lifted all those restrictions. However, I would say that even on the plane, if they take off mask, I would wear my face mask. It's just the way I am. I think since this is a respiratory virus, depending on the quality of air around you is something you need to keep in mind. So I am always vigilant in that regard. In regards to young children, can I be exposed to my niece or my nephew, their babies? And I say, I'm not sure about their immune system. You've had the vaccine. It's highly unlikely you will be able to, they transmit anything back and forth. So if you are concerned, then wear a face mask, but please enjoy the hugs. It's important. Those are some of the questions I can think about that others would ask. I don't know, did we get any other questions in?
Not at this point.
All right, so one other thing that should be kept in mind, we do have in our oncology division, like I said before, our social worker and our nurse navigator, they work quite hard in making sure that from a psychosocial standpoint, the patients are all, kept close to the vest. And I know they've started a lot of outdoor, or social work has started a lot of outdoor events for our oncology patients who have been treated. and or are recovering. And so you can always contact our office to find out more about that. That is something we have been doing. And I think I've kind of exhausted all the questions I can think of. Then in that case, we ended probably a little bit early. My apologies, but that is how we treat our patients here at York Hospital. And we look forward to continuing the care that is geared towards first and foremost, patient safety. I am extremely proud of York Hospital for how it's approached COVID, and to our nurses here in the oncology department, and to all our team, those at our front desk who has had to answer multiple questions. Why do I need a mask? Why do I need to be pre-screened? They have been extremely patient, which is what we require of all our employees when we deal with patients who are in a vulnerable position. Once again, thank you so much for joining me and for hearing this talk on how COVID affects us in the Cancer Center.
Wonderful. Thank you, Dr. McLaughlin, and thanks everyone for joining us today. And just a quick reminder, if anyone has any questions that they think of later on, please don't hesitate to send them to the Community Relations Office at info@yorkhospital.com, and we'll get right back to you. Thank you, everyone.
Thank you.